Good afternoon, everybody. Thank you for joining this e-seminar organized by the ERA CKD-MBD work group in collaboration with the European Society of Pediatric Nephrology. And the presentation of today, as you can read, is endocrine functions of the bone and their potential contributions to systemic CKD complications. This is a very new aspect. I could say this is a developing aspect of bone, which is becoming an even more complex tissue organ in the body that we are trying to understand in its specific and endocrine functions. And it is also, it is not by chance that the pediatric nephrologists are involved, because there may be differences in bone function in an adulthood and in childhood. And so the seminar of today, that is, I can say it is, should have been moderated by Mathias Loberg Haarhaus, but he is having some practical problems and he cannot join us. I'm trying to substitute him together with Justine Bacchetta. I'm Sandro Mazzaferro from Rome, Italy, and Justine is from France. She is a pediatric nephrologist, and I think that she can also say something about this seminar here. Please, Justine.
Yeah, thank you, Sandro. So good afternoon, everybody. It's a real pleasure that the ESPN CKD-MBD working group can participate to this ERA webinar. And in fact, you will see that bone is an endocrine organ and that it begins very early in life. So maybe we will have a discussion and interactions on this wonderful organ during the spectrum of CKD. And it is our real pleasure to introduce today our speaker, Dr. Juan Miguel Díaz Tocados from Spain, and he's a PhD. He's a researcher in a lab, and he's working on CKD MBD in Jeddah in Catalonia. So we will have his lecture for 25 to 30 minutes first, and then we will have 30 minutes to have a complete discussion together. So please don't be shy and ask your questions in the Q&A part during the talk. Juan Miguel, the floor is yours.
Thank you for the kind presentation, Justine. Thank you for the kind presentation, Sandro. I had no disclosure of interest in this seminar. I would like to aim in the bone endocrine action. There are, as you know, there are many actions of the bone related to storage of minerals, phosphate and calcium mainly, and also respect to its function and in the organ protection and also the locomotor activity. Despite all this function, the bone also had important function as an endocrine organ by secreting cytokines that are called osteocalcins that can act directly in the bone as in a paracrine manner, but also can be secreted into the bloodstream, targeting many organs and inserting, triggering many diverse function, extraskeletal function. As you can see here, these molecules secreted by the bones can reach the pancreas and activate or regulate energy metabolism, increase muscle mass via mechanical loading, control gonadal function, and also neurocognitive functions. And I would like to emphasize that maybe the bone reaches a peak of relevance respect to its endocrine functions. When the discovery of the phosphatory hormone ATF23 in 1994, then 6 years later, the ATF23 was characterized as a molecule secreted by the osteoblasts and osteocytes, regulating phosphate resorption and also vitamin D metabolism. This hormone, this bone hormone, reached a peak of importance in the field of nephrology because of the relation of its relationship with mortality, which was associated with mortality, and also with the CKD progression. Now, many years later, or a decade later, you can see that here all the functions that are related to AGA23. And in this seminar, I will want to be focused in this function because cardiovascular functions are very heterogeneous and well, they are investigated in many studies, and also AGA23 is very famous in the field of nephrology. So I'm going to focus on other bone hormones that are important in the regulation of many skeletal functions. One of them is very known for nephrologists, that it is the neutrophil gelatinase associated Lipocalin, also known as Lipocalin 2. Lipocalin 2 is a protein that is overexpressed when in the case of inflammation, in the inflamed tissue, and in end-stage renal function, the Lipocalin 2 levels are increased, and also as associated with the glomerular filtration rate indirectly. It's important to note that this Lipocalin 2 is increased in acute kidney injury and also in transient azotemia and chronic kidney disease patients in comparison with this subject with normal renal function. But more recently, also the renal Lipocalin production has been related to the increase in the bone AGA23 levels that in turn target the heart and can produce or induce left ventricular hypertrophy. In addition to its function in the inflammation and the regulation of the regulation of AGA23 metabolism, Lipocalin 2 is also involved in energy metabolism, since the animals with osteoblastic dilation of Lipocalin 2 and reduce its serum levels by 67%. That is a very important reduction, not in other organs. While in other organs, the Lipocalin 2 remains similar in these animals. This animal also display an increase in blood glucose that was related with a reduction of the pancreatic cells, the number of pancreatic beta cells areas and the number. This action was associated with the reduction of the osteoblastic Lipocalin secretion and were reversed by administration of Lipocalin 2, exogenous administration. This is because the osteoblastic secreted Lipocalin to the bloodstream is able to cross the blood-brain barrier and bind the melanocortin 4 receptor in the hypothalamic neurons, and that suppressing appetite. In normal weight volunteers, here you can see how after meal the decrease in the feeling of hunger is associated with an increase of the serum lipocalin levels. And here you can see how the hunger score is inversely correlated with the serum levels of lipocalin. This increase in the lipocalin serum levels were not observed in patients with overweight or obese, and this association was also not found. But in patients with severely obese that had a gastric bypass, slightly recover the lipocalin mechanism or the lipocalin levels, and showing also a better correlation despite not significant. In experiment with monkey, you can see here how the animals with the monkeys with administered with lipocalin, with exogenous lipocalin 2, reduce the food intake. So in primates, also this mechanism is working well. Here you can see a summary figure where I would like to summarize the result in this paper by Olson, where pancreatic patients with pancreatic cancer saw an increase in the bone production of lipocalin, which in turn is secreted to the circulation, reach the hypothalamus, bind the melanocortin 4 receptor neuron, and induce anorexia. This loss of appetite is also very common in patients with advanced CKD, and a role of the high lipocalin levels have not been still explored. Lipocalin levels that maybe are increased because of the inflammation in the kidney, but also in the bone. Another important hormone that are related to glucose homeostasis and energy metabolism is osteocalcin. Osteocalcin is a bone binding calcium binding protein that is also found in the bone, in the matrix, and is also rich in gamma carboxyglutamyl amino acids that are the vitamin K dependent. The levels of osteocalcin have been extensively used in research because it's a marker of bone formation. When you differentiate the mesenchymal stem cell into osteoblasts, the mature osteoblasts are able to express osteocalcin or high levels of osteocalcin. Also, in patients, is a marker of osteoblastic activity as osteoblasts are more active. They secrete osteocalcin to the serum that can be measured, and you can see how the osteoblastic activity is. Well, this osteocalcin is also involved in the regulation of glucose metabolism. The Gerard Carcetti research group, which had explored the osteocalcin endocrinology or endocrine function a lot in the last decades, they found that animals lacking a tyrosine phosphatase in the osteoblast had an increased levels of serum insulin and also decreased blood glucose. These animals were protected against the glucose intolerance and diabetes induced by the tetrodotoxin administration or high fat diet. They identify osteocalcin as a main endocrine factor that was able to develop this action on glucose metabolism, as the ablation of the double mutant of osteocalcin and the protein with that tyrosine phosphatase prevent these phenotypes. Here you can see how administration of Osteocalcin, a solid administration, result in a complete recovery of the phenotype. That the Osteocalcin was able to increase beta cell proliferation, energy expenditure, insulin sensitivity, and decreasing adiposity, and also increasing adipocyte metabolism. Furthermore, in addition to the pancreatic cell, there are many other cells in the body that express the insulin receptor. The insulin receptor is also expressed in the osteoblast, and the animals with osteoblastic deletion of the insulin receptor show a decrease in the insulin levels and an increase in the blood glucose. This is because this animal was that are deficient for the insulin receptor had a decrease in the osteoblast in the secretion of the osteocalcin to the bloodstream, as the double mutant for insulin receptor and osteocalcin normalize this phenotype. The activation of that occurs because the activation of the insulin receptor or the insulin pathway in the osteoblast results in an increase of the bone resorption. This bone resorption, when this bone resorption is prevented by administration of biphosphonate and endronate, this effect of the insulin in the osteoblast and in the glucose metabolism is also prevented. This is because the insulin is able, the osteoblasts are able to sense the insulin that increase the RAN ligand, the osteoblastic activity via RAN ligand ratio increase, and are able to and release the osteocalcin from the bone matrix, and the acidification of in the site of the reabsorption also increase, and the carboxylation of osteocalcin, which target the pancreas, the adipose tissue, and had the insert dysfunction on glucose metabolism. Another bone hormone that are related to bone metabolism and very well known by all in the field of nephrology is the sclerostin. Sclerostin is produced by the osteocyte that are embedded in the bone matrix, and this sclerostin is able to target the osteoblast and the osteoclast, increasing the osteoblast activity and decreasing osteoblast bone formation, osteoblastic bone formation. In this regard, the pharmacological industry had developed sclerostin again, neutralizing antibody against sclerostin that can increase bone formation, as you can see here, respect to placebo. This occurs because it had the dual activity, decreasing bone resorption and increasing bone formation. In addition to this function, this bone function, and the sclerostin also had a role in the control of energy metabolism. So the animals with a loss of function mutation of sclerostin had a lower side of the adipocyte and lower content of fat mass, increasing or decreasing the ability of this animal to develop adipocyte dysfunction. On the contrary, when these animals are injected with an adenovirus expressing sclerostin or overexpressing sclerostin, the animal saw an expected decrease of the bone volume and also increase the fat mass and decrease the lean mass. This animal also were administered with sclerostin antibody to inhibit the sclerostin, and the animals fed a fat diet saw a decreased body weight and also a decreased fat mass. This is important in the field of chronic kidney disease because as chronic kidney disease progress, an adiposity function is found, and also could be related to sclerostin levels that are increased in the patients with chronic kidney disease. Another important point in the role of bone as not really as an endocrine organ, but affect the energy metabolism is the increased activity by hypoxia inducible factor signaling. Here you can see how animals knock out for the von Hippel-Lindau factor compound that result in an accumulation of HIF and activation of the hypoxia-inducible factor signaling, reduce the fat mass, and also reduce the total body weight. This is because the animals are able to increase the glucolysis and glucose uptake, reducing the circulating glucose levels. These effects were independent of the serum osteocalcin or even in the serum insulin levels. As you can see here in this summary figure, the increased glucolysis by activation of the hypoxia inducible factor decrease the glucose level and can prevent or protect against glucose intolerance. This is important in the field of the nephrology because of the recent approval of the hypoxia-induced or the HIF hydroxylase inhibitors that result in an increase of hypoxia in hypoxia signaling. In another complication that is very common in the field of nephrology is sarcopenia, that as renal disease progress, here is CKD progression is CKD progression advance, the muscle become lower or muscle mass decrease, and can result in sarcopenia. Importantly, the patient with dialysis or all patients had lower muscle mass or renal patient, but those on dialysis show the greater risk of sarcopenia. And this is important because sarcopenia and mortality risk in dialysis patient is associated. It's important to highlight that the absence of mechanical loading or the limitation of motility can result in the decrease of the bone mineral density. This is demonstrated by the space flight or the space travelers that decrease the bone mineral density 1.2 and between 1.2 and 1.5% per month at the hip. This is a very huge decrease in comparison with menopause. That is important, but imagine that this bone mineral density in menopause decrease between 1.2 and 1.5% per year. So these are very huge changes. These changes are the responsible cell the responsible sensory cell for mechanical loading is the osteocyte that is embedded in the bone matrix, and the proteins involved as a receptor of these signals are related to focal adhesions, gut junction, or primary cilium. Very briefly, the mechanical loading when mechanical loading increased, the osteocyte decreased the production and secretion of sclerostin, then in turn activate the osteoblast or increase osteoblast activity and bone formation. The primary cilium is an organelle that extends from the cell and is able to sense the mechanical loading or the changes in the microenvironment. Here you can see how the polycystin 1 or polycystin 2 are two proteins that are related to or are important in the transduction of these signals. And these polycystin 1 and 2 are encoded by the gene PKD, polycystic kidney disease 1 and polycystic kidney disease 2, that when they are mutated or had a loss of function, result in a disability of the primary cilium and develop polycystic kidney disease. Here you can see in this study in polycystic kidney disease patients where the serum markers of bone formation and the serum markers of bone resorption are reduced in patients with autosomal dominant polycystic kidney disease in comparison with controls CKD patient with a similar degree of disease. In addition to this bone alteration, this patient with a primary cilium mutation or inability had also increased sclerostin, increased serum phosphate, and also increased serum FGF23, which had important metabolic functions. In respect to intervention to increase mechanical loading, or the exercise could be a good intervention. This is a very recent study, including patients or older patients or adults with CKD 3 to 5 and not in kidney replacement therapy. And after 1 year of exercise, the results were not very promising, but was a slight increase in the T and Z score in the balance group that had a no very aggressive exercise. And also it's important to highlight that this patient also had a slight decrease in the glomerular filtration rate, not very high, but significant. This is very important because in animals with in an animal model of CKD, voluntary wheel running was beneficial, and for CKD MBD disorder, not only for preventing cortical porosity and bone strength, but also decreasing PhD, phosphorus, the renal function parameters, and also the cystic kidney weight. So this mechanical loading can also be beneficial not only for bone but also but for many other systemic benefits that can be sensed by the osteocyte or maybe other organs or can be involved. But the bone can also exert an important role in this regard. Here you can see a study in which human volunteers resting around 2 weeks results show an increase in the serum Lipocalin levels. As you can see, after 2 weeks, the serum levels were significant. This also occurs in mice with transient paralysis induced by Botox administration. This Botox administration results in a decrease of bone volume, but also in an increase of the osteoclast of the bone surface covered by osteoclast and decreased osteoblast surface. These animals with transient paralysis also had an increased expression of Lipocalin 2 are also increased serum Lipocalin levels. Despite the mechanism involved in these changes and the biological significance is not really clear, it could be related because it could be related to the decrease or the suppression of appetite in situation where energy expenditure is low. In addition, bone regulation of muscle mass can be also controlled by osteocalcin levels. Here in this study, the calcentive group also observed that total osteocalcin increased in animals after running, and the insulin levels were decreased. These were associated with an increase in the uncarboxylated osteocalcin, the undercarboxylated osteocalcin, the bioactive osteocalcin, and also an increase in the markers of bone resorption. In animal with osteocalcin ablation in the osteoblast, the distance and the time that this animal were able to run was reduced, and also this was similar. This similarly occurred in animals with a deletion of the GPRC6A receptor. Administration of osteocalcin result in partially prevent or partially increase the distance and time that this animal can run. And this was because the osteocalcin that secreted by the bone can target this receptor in the muscle cell, increase the nutrient uptake, fatty acid, and glucose, and increase the production of interleukin-6 by the muscle that target the liver and the adipocyte and increase the energy release. This is important, but also could have controversial actions in the field of nephrology or in the context of renal disease, because the GF23 is increased by or interleukin-6 is one of the factors that increase GF23. So if these interleukin-6 levels are enough to increase GF23, could be controversial, but maybe remain at systemic level and remain at local level. Sorry. Respect to gonadal dysfunction that are also very common in chronic kidney disease patients. The bone also is a very important function. Here you can see how, as chronic kidney disease progress, the levels of testosterone decrease significantly, and these levels of testosterone are related to a decrease in the sperm count and fertility. Here you can see in this graph the prevalence of the end-stage chronic disease patient with testosterone insufficiency or testosterone deficiency that count together more than 75%. This is important because the exists a significant association, a very interesting association between the insufficiency and deficiency levels of testosterone and the risk of mortality in end-stage renal disease. Well, in this way, the calcentive group also report osteocalcin, a function of an endocrine function of the osteocalcin produced by osteoblast in the gonadal function, as the animals with osteocalcin, osteoblastic deletion of osteocalcin decrease the sperm count and the gonadal size. These Leydig cells were cultured or co-cultured with osteoblasts increased the levels of testosterone, but were not able to increase testosterone when cultured with osteocalcin deficient osteoblasts. And also administration of osteocalcin increased testosterone. And this increase of testosterone by Leydig cells were not related to the luteinizing hormone. Here you can see how this association between testosterone and osteocalcin, and how the osteocalcin was found in the bone but not in the testes. These effects of the osteocalcin on testosterone production and gonadal size were related to the bind of the osteocalcin with the GRC6A receptor. In the field of nephrology, here you can see in this slide how in children with CKD the testosterone levels was associated was increased as the bone age. This increase was or reached a peak at the same time as osteocalcin, and a similar time of the osteoblastic of the serum marker of osteoblast activity. However, when after correlation analyzed and adjusted by bone age, osteocalcin was associated with testosterone and the periosteal circumference, but no, testosterone was not associated with the osteoblast, with the serum marker osteoblast activity. That this can indicate that the osteocalcin, the bone growth and testosterone are the three factors or the three variables are related. It's important to highlight that osteocalcin clearance is importantly increased in end-stage renal disease children, as you can see here. And in the dialyzed fluid, osteocalcin increase after the season, and the serum level decrease. So this can be a reason behind the decrease of bone mass or the decrease of bone growth in these children. Another important complication in the CKD patient is the cognitive impairment that are usually related to uremic factor and vascular damage, but also the bone release a lot of or an important number of cytokines that can target the brain and increase or produce neurodegeneration. As you can see here, the animals with knockout for osteocalcin had a lower locomotor activity and ambulatory activity, and this animal had a walk very, very weak and surrounded the cage. But this was not related to the same receptor or previously discovered to have glucose effects. Also, this animal with osteocalcin dilation had a decrease of on many neurological factors, the dopamine or neurotransmitter, dopamine, GABA, serotonin, or norepinephrine. And also, animals with haploinsufficient or FRUN2 displaying impairing spatial learning. Here in the Morris Water maze, that the mouse had to find a platform in the swimming area, the animals deficient in or with haploinsufficient or rank 2 need more time to learn where the platform is, and more time in general. Yeah. These animals also had decreased osteoclastic activity and a reduction of the osteocalcin levels that can be related with this cognitive impairment. These effects were not related to the same receptor, but the author then demonstrate that the receptor responsible for the cognitive lesion of osteocalcin were the GPR 158. Also, osteocalcin is related to myelinization in the oligodendrocyte. This enzymes are triggered by the activation of the GPR 36. In addition, another well-known bone protein, bone cytokine released by the osteocyte, the sclerostin, is one of the protein that increase its levels as the human age, and this sclerostin have been associated with impairment of cognitive function during aging and Alzheimer's disease by accumulation of the beta amyloid protein in the plasma and also in the brain. This is also important in the field of nephrology because patients with low function or decreased kidney function had also increased levels of the beta amyloid protein that can be related to the decrease in the clearance, but also an increase in the production. Finally, I am going to show that ADPKD can be also found in the cerebrospinal fluid, and an in vitro experiment has shown that hippocampal neurons treated with ADPKD show lower critical radius and lower arborization and ramification, and also saw an increase of the synaptic density that was prevented by administration of clotho and the pan-EGR receptor inhibitor SU5402. This is important also in the field of nephrology, or this effect of ADPKD in cognitive impairment have been also observed in patients, in children with chronic kidney disease, that in which the children with the highest ADPKD tertile had an increased cognitive impairment as assessed by cognitive function tests such as the omission error or the hit reaction time. To highlight that we are so far, we are still very far away to know how the bone.
Juan,
Yes.
try to go to the conclusions.
Okay. And then this author discovered that 375 new osteokines. Among them, the effective active binding protein 3 osteokine is related by the osteoblast senescent, by the senescent osteoblast that target the vessel smooth muscle cell and increase related or senescent related atherogenesis. And this my conclusion, that the bone produce a variety of hormones that regulate multiple function at systemic level. Chronic kidney disease had an important complication that can be associated with these osteokines. The principal role of this osteokine in the control of osteoskeletal function in the CKD context may suggest novel biomarkers and also even target internal disease patient. And then also replicating this study in chronic disease condition could confirm whether these osteokines display relevant effects on the progression of renal disease and associated complications. I would like to invite you to the next Europe Winter meeting that will be in Leuven, the next 15th of January, and the ATRA submission is open until November 15. Thank you very much.
Okay, thank you for this exhaustive presentation on the bone effects, the endocrine effects of bone. I think this is very, very interesting presentation with many new details and new open possible questions. Among the ones that we received, there is one if there is any evidence that osteocalcin could be a predictive potential parameter of insurging diabetes, especially in transplant patients. So do osteocalcin levels may represent a biomarker of risk of diabetes, risk of developing diabetes? Is there any paper in the literature dealing with this subject?
Yeah, in my opinion, I did not found any. I didn't find any paper respect the transplant patient, but the patient with diabetes also had a decreased level of osteocalcin or an increased level of or a decreased level on under the carboxylated osteocalcin. This can be related to impairment in the response to glucose level. Maybe it is better to consider the measurement of this osteocalcin level in this patient when they are not responders to classical therapy. But I think that this is a consideration more than a target so far.
Well, I don't know if there may be some specific consideration of osteocalcin in children, because to my knowledge, in adulthood in human, there is a limited clinical evidence of the role of osteocalcin in the energized metabolism.
Yeah,
But
so
there may be some difference in childhood.
yeah, so maybe Sandro, I can try to answer. So as you have seen from Juan, Miguel, and congratulations for this talk. It was completely amazing, very busy, but it gave a wonderful overview. And then osteocalcin in children, you have seen there is a puberty peak in the Kirmani paper, both in girls and boys. So it's always difficult to say something because you don't have stable levels among puberty. That said, there is one paper in patients with osteoid. Do you know the osteoid osteoma? You know, it's a benign bone tumor that is over-secreting osteocalcin. And it's a paper from Lyon and the US, showing that in patients in which you remove the tumor, then you have a drop in osteocalcin levels, and then you have a significant increase in glucose levels in the short hours just after surgery. So it's a proof of concept that indeed in patients, osteocalcin can regulate glucose metabolism, but it's a very rare disease, you know, and it's a small proof of concept, but maybe it answers partly the question, Sandro.
Okay. It seems that it could have a role as an adaptive response to some clinical conditions. Okay, and there is also another question, this one from Jordi Bover. When you are using the antibody against sclerostin, romosozumab, is there any evidence that there is an effect on adiposity or body weight that you might know, Juan?
Did not found any study in clinical patients, but sure that the administration of the Sclerostin antibody may decrease fat mass. But I don't know if there are a clinical study considering this measurement.
Okay. Well, I don't know if there may be other comments. There is because there are some questions from the audience, but are mostly directed toward clinical practice behavior, clinical therapeutic choices. And I don't know, we can try to move to a couple. One is, what is the target of PTH to avoid a dynamic risk? Well, I think this is a very difficult question to answer. But I don't know if Juan or I can also say that let's ask first to Juan. Then I would ask to Justine if for the pediatric patient, and then to myself if there is differences in adulthood. Please, Juan. What's your target of PTH?
Targets of PTH for a dynamic the bone.
To avoid a dynamic or to reduce a dynamic risk.
To avoid a dynamic. I don't know, maybe increase the values of PTH are the best consideration for increase the bone remodeling in a dynamic bone. I think that administration of ROMO can be a little bit can be a risk in the chronic disease patient, also in those with an dynamic bone that maybe are patient in stage renal disease, because in pre-dialysis that dynamic bone, I think that is less prevalent, and this patient in an stage renal disease can be in a high risk of cardiovascular disease. And then the recent study has shown that the expression of sclerostin in vessel smooth muscle cells can prevent from vascular calcifications on systemic inhibition of sclerostin should be a risk to prevent this adynamic bone in chronic kidney disease patients. And then maybe in the future to develop a new treatment to target sclerostin expression directly in bone cells can be a good option.
Yeah, so to date, obviously, we cannot modulate sclerostin pathway, at least in pediatric CKD. And the thing is that in children, so I will just focus on children on dialysis, because the question is very difficult for PTH targets. And in children, we use more active vitamin D analogs and less calcimimetics. So it's true that there is a risk of adynamic bone disease if we overuse calcium supplements and active vitamin D analogs. There is an old paper based on bone biopsies from the US showing that if you have alkaline phosphatase around 400 and PTH around 400, you are probably good for bone turnover. And what we say in Europe is that usually we are a little bit more conservative than our American colleagues. And in pediatric dialysis, if we have a PTH around 2 to 3, the upper normal limit of the assay, it's usually a correct thing. But then you have obviously to check growth because a child who doesn't grow may have a dynamic or secondary hyperparathyroidism. If the growth is correct, it's a good indication that your CKD-MBD is quite well controlled. But we do not have very high evidence, to say that. I think Mathias wants to say something. He has a hand up. No? No, he disappeared again. Mathias, do you want to add something?
Yes, hello. Hello, Justine, and hello, everybody. I'm very sorry I was not in the meeting from the beginning, but I was stuck at an airport after a very, very late flight. So I think this is a very interesting question. And Sandro, if you allow me just to come with a short comment before you will round this question up. I would say maybe the question is a little bit, I would rephrase it. Don't target PTH to avoid adynamic bone. Look at the bone turnover markers, because they really tell you what is going on in the bone with a pretty good degree of correct answers. So I would recommend to look at bone alkaline phosphatase, at tartrate-resistant acid phosphatase, maybe the intact P1MP also, and target them. Now that, of course, raises the question, what are the target levels? And these, I think we need to define better. But look at them, see if anything happens. If they go down, it's not a good sign. If they go down to very, very low, maybe. And this is the other thing, how to target. And I would say the way to target adynamic bone when it becomes dangerous is you should give your patient adequate nutrition. This is, for me, the first and most important treatment for adynamic bone, or for avoidance of adynamic bone. And the other part is treat diabetes correctly. So it's more or less treat the basic condition that can make the low bone turnover deleterious. And then, of course, you should avoid over suppression, over treatment with calcium, vitamin D. This is currently what I would suggest.
Well, and if you allow me to add something to what you said, that can be pointed also toward what Juan tried to indicate us, that bone should be regarded as a very special inner sensor that is responsible for regulation of energy metabolism and a number of endocrine functions that have to do, that are dealing with growth and also physical exercise and a number of other activities. And I think that it is a mechanical sensor, a biochemical sensor, and produces a number of answers. We have been dealing with some of these potential biomarkers like alkaline phosphatase, indirectly PTH, vitamin D, but now we should move towards more biochemical targets that will indicate us what's going on at the level of bone cells, and this can be responsible for other systemic effects. I don't know if you want to add other commentaries on this, Justine, or even Mathias.
If I may add a small thing, yes, from the pediatric perspective, thank you, Sandro. I would say that we have learned in the recent years that some very rare renal diseases, for example, cystinosis, may have specific bone impairment because of the effect of the mutation directly in bone. And Juan Miguel also touched the subject with ADPKD, with polycystin 1 and 2 mutations with defect in the primary cilia. There are very nice experimental papers showing a direct effect on osteoblastic activity. And probably we may gain a better understanding on this very complex pathophysiology in bone from the rare diseases, and then maybe apply to all patients with CKD. So it was a small comment from the pediatric part.
Okay, I don't know if Mathias wants to add something, because we need to close. And also Juan, well, one thing that I did not say from the question and answer, that you received congratulations from more and more people. So a very good presentation. Mathias, do you want to say something and close the session of this seminar?
Thank you very much, Sandro. Yes, I can do that. So maybe one last comment since you asked. I do agree, and I think also that this was a fascinating session, giving us insights into both pathophysiology and also the disease phenotypes that are associated with the endocrine disruption of the endocrine functions of the bone. And it's a fascinating, evolving area. We are learning more and more. We are learning how nutrition, how physical activity and bone energy metabolism are very much entwined, and this also involves cognitive function. So it's a fascinating organ. And there's one interesting study done by Denise Mafra in Brazil. She did a very meticulous intervention using both nutrition and physical activity in dialysis patients with a very nice effect on bone mineral density. So this is a paper I think everybody should try to read and see how much you can do when you address this on a larger scale. But I would like to hand over to Juan for maybe some final comment, and then I can round up the session.
Okay.
Thank you very much for your assistance and for your company here in this seminar. And I would like to highlight that maybe to control bone or to check how bone is the bone stage by serum markers, you can is depending on depend a lot of the patient. So it is very difficult to establish a target or establish a range for all the patients because there are many subjacent different diseases. There are many different patients, different genetic background, different physical activity or nutrition, how such as Mathias comment. So it's very difficult to establish this. So the way is personalized medicine from my point of view. And then this is my final comment. Thank you.
Okay, I think we need to close. We thank everybody. And I think for those who are interested, let's see in Leuven for the EUROD meeting, which is very focused on these aspects of bone disease. Thank you very much to everybody.